Another surgical emergency. Absolute constipation, multiple episodes of vomiting, and abdomen is distended like a drum. This is a very classic case and very important one. So we have a 60-year-old female with a history of previous hysterectomy and presented to us with the features of absolute constipation. That means patient is not able to pass flatus or feces for last 3 days. Along with that, she is having multiple episodes of vomiting, like 8 to 10 episodes per day for last 3 days. On examination, abdomen is grossly distended. There is tympanic note on percussion, and there is visible peristalsis, and we are able to see bowel loops across the abdomen. And on auscultation, bowel sounds are present, and these are high pitched. An investigation on an X-ray abdomen, you can clearly appreciate there are multiple air fluid levels in the bowel, and small bowel is dilated, but there is no gas in the colon. So, what do you think? What is the diagnosis of this case? Is it acute gastroenteritis, small bowel obstruction, or paralytic ileus? Yes, you guys guessed it correctly. This is a case of acute small bowel obstruction. So, what are the causes? The most common ones are adhesion. Other can be some malignancy, hernia, volvulus, gallstone ileus. And there can be paralytic ileus. The causes are post-operatively, some electrolyte imbalance, and some drugs. X-ray findings are classic hallmark for this small bowel obstruction. A small bowel dilated more than 3 centimeter and a large bowel dilated more than 6 centimeter with multiple air fluid levels. This pretty much diagnosed this is a case of small bowel obstruction. And remember, in ileus, there is dilatation of complete bowel, including small bowel and large bowel. But in this small bowel obstruction, the large bowel is collapsed and there is dilatation of only small bowel. And for the diagnosis part, the clinical features are absolute constipation, that means not passing flatus and feces, recurrent episodes of vomiting, systemic toxicity, and abdominal distension. And investigations, we can go for abdominal X-ray, we discussed earlier, and a CT scan, in which we can get a transition point. Most of the time, we can get a transition point like where there is obstruction. And the management part is, firstly, we can go for a conservative management. We go with IV fluid, IV antibiotics, and nasogastric decompression. We can monitor the patient. If the patient is not improving, then we can go for exploratory laparotomy and find out where the obstruction is, and do adhesiolysis, remove any kind of band or remove any pathology that is causing that obstruction. And after that surgery, we might go for a resection anastomosis and stoma formation depending on the patient's condition. So this is another important case, another interesting case, and very important for your surgery exam. So do share it, do save it, and do follow Diagnose It for more such interesting cases. Thank you.